Good morning, ladies and gentlemen. In the next 20 minutes or so, I'd like to take you through 5 points in relation to this never-before opportunity to meet the contraceptive needs of adolescents. So what is this never-before opportunity? First of all, there's this recognition, this worldwide recognition that we're not meeting the needs and fulfilling the rights of adolescents to contraceptive services. The Guttmacher Institute published this excellent report earlier this year, and it points to the fact that in developing countries, 38 million adolescent women need contraceptives to avoid an unintended pregnancy. So these are 38 million adolescent women who want to postpone birth for at least 2 years. And what you see here is that more than half of them are not using an effective method. So a huge unmet need in adolescence. And the consequences of that are very clear. Consequences in terms of sexual and reproductive health problems listed on the slide, but also consequences in terms of lost opportunities for them to study, to grow and develop to their full potential, not just as economic agents, but also as individuals. And so there are social costs and economic costs as well. There's also very important recognition now, much more than in the past, that just making contraceptives available to everyone in the community does not necessarily mean adolescents will use it. There's lots of data. You know, the recent DHS from Malawi shows that women in the 20 to 24 years age group are here. Women in the 25 to 29 years age group are here. But adolescents have improved, like the slide in Egypt, but not as much as the others. So we need to do more. Of course, we need to make contraceptives available, but we need to do much more than that. So FP 2020 is an initiative which was launched in 2012. It's not a project, it's an initiative of many players. And this year, FP 2020 is celebrating its midpoint. And one of the things in this report, which is available on its website, is that over the last 4 years, there are 30 million new women and girls who are using contraception throughout the world. 30 million women. Of course, it's not FP 2020, it's not a project, like I said, and it's not taking credit for this on its own. It's the collective efforts of many players, including the efforts of several European countries, including Belgium. Well, one of the key messages is this, that their call is we need to strengthen the way in which countries are addressing adolescence. Because again and again and again you see that countries are hugely uncomfortable for some reason, don't want to deal with the issues of adolescence. So this was a call, and in the FP 2020 reference group meeting in Dar es Salaam in September, this was one of the issues discussed in depth. But this is not the only opportunity. There are huge other opportunities. Child marriage, for instance. A lot of the childbearing that occurs in many developing countries occurs within marriage. Abortions occur outside. Abortions occur also in the context of marriage and union. But a lot of births occur in union. And there's a huge multi-government supported effort to prevent child marriage. Serious money on the table like we've never seen before. Serious money on the table for HIV prevention work as well. So there's an opportunity, a never-before opportunity to address adolescence and address adolescent contraception in the context of all these issues. So why adolescents are unable to obtain and use contraceptives? So one issue is that they are not able to obtain them. They're not able to obtain them because they're not available or are out of stock. They're not available, they're available, but laws and policies prohibit their provision to unmarried adolescents or adolescents below a particular age or adolescents who are disabled. There are still laws in countries where you cannot provide contraceptives to some groups of adolescents. And even when there are no legal or policy barriers, for example, in Tanzania, we'll come back to Tanzania, no legal and policy barriers. There are huge other barriers. Health workers do not provide contraceptives because of their personal biases or because of their medical knowledge, lack of knowledge. They do not provide long-acting contraceptives. Many health workers in many places say, have your first child and come back and then we can talk about contraceptives. And also, adolescents don't know about contraception, don't know where to get contraception, they cannot afford them in many places, and they are sometimes provided in facilities and at timings that are difficult for them. The other issue is, even when they can obtain contraceptives, many adolescents are unable to use them and to use them consistently because of pressure to bear children. So you can obtain them, but I can't negotiate contraception use with my husband. So I'm under pressure from my mother-in-law, from my sister-in-law, from my family to have a child. And if it's a female child, to have another child till you have a male child. There's stigma. You can't talk about contraceptive use. There's a lot of pressure there. And lack of knowledge. So, we published a paper synthesizing some information from several systematic reviews where we had, from South Africa, saying, I pop in a pill just before my boyfriend comes. So you have those kinds of issues. And Pop Council published a report on contraceptive discontinuation. So these are adolescents who are already using modern contraceptives. Their discontinuation rates are double or more than double that of adults. So there are huge issues, both in obtaining contraceptives and in using them and in continuing to use them once you've started to use them. So what do we do? What do we need to do and do differently to meet the needs and fulfill the rights of adolescents? So this is the heart of my presentation. First thing we need to do is to remove barriers, legal and policy barriers. Population Reference Bureau prepared this little document in advance of the FP 2020 reference group meeting. In many countries, there are no barriers. Tanzania is a case in point. There are no external authorizations, no age restriction, no marital status restrictions, but there is in the DRC. And there are in many, many other countries, particularly in South Asia and East Asia, huge restriction, but also in Latin America. You have all this in Brazil, for instance, you have the street parties, the carnivals, but if you look at the contraceptive laws and policies and procedures that are applied, they are highly restrictive. So this is an important issue to address. 5 things to do in the context of service provision. One is we must move from a one-size-fits-all to meeting the needs of different groups of adolescents. In the past, when we think about adolescents, we think about a 19-year-old unmarried college-going adolescent or a out-of-school adolescent. Actually, there are many different groups of adolescents. And look at this data. This is a beautiful secondary analysis done by my colleagues Michelle Hinden and Amanda Calamar. And I'd just like to take you through this in a minute. What you have here are Tanzania. As I said to you, no policy barriers, no legal barriers. But look at this. On this slide, we have girls in union. We have unmarried girls. So in non-using, 60% of unmarried adolescents are not using contraceptives. These are girls who are unmarried, sexually active. Main reasons for non-use, main sources are shops. I'll come to that in a minute. And look at this here. Look at non-use is 85% in married adolescents. Currently breastfeeding, not having sex, fear of side effects. Where do you get it? Government facilities. What you have is 2 groups of women, same tribe, same language, same age. It's almost like 2 different species. The contraceptive use rate, the contraceptives they're using, where they're getting them from, Why we are not using, completely different. And you see this pattern repeated again and again and again. And if you take disabled adolescents or adolescents living with HIV, and there are huge numbers of them in Eastern and Southern Africa, so then you're dealing with a whole spectrum of needs and which are different and need to be met differently. Second thing is we must expand the range of contraceptive choices that are offered to adolescents. Even where contraceptives are offered, they're often condoms and pills. And WHO very clearly says, and I think many organizations clearly say, that there's no medical reason to withhold any contraceptive methods from adolescents. With the exception of sterilization, there's no really a real good reason to withhold any other method. Obviously, this needs to take into account their lifestyles, their circumstances, the relationships they're in, etc. The third one is we need to move from this separate, standalone, youth-friendly adolescent clinic to making existing services adolescent-friendly. All over the world, we have invested in standalone adolescent clinics with a nice board, blue paint on the walls, posters and leaflets with no adolescents coming there. What we really need to do is to reach the adolescents where they are in antenatal clinics, in antiretroviral clinics, in post-abortion clinics, in post-abortion care. Many African countries, we have this abortion summit going on in Addis currently. Many African countries, Ghana, Ethiopia, Zambia, are moving ahead with abortion services, moving away from the post-abortion care to providing safe abortion services without restriction. And we have to tie in contraceptive service provision with that. The next thing is we need to move away from the idea of the clinic to reaching adolescents where they are and where they are already going to, where they're hanging around in street corners, in schools, in workplaces, but increasingly in pharmacies. I shared this paper with Christine a few weeks ago. Look at this very interesting paper from Nepal. So what you have is adolescents know, these adolescents knew the other methods, they had used the other methods, but they decided just to use emergency contraception as their first line measure or method of contraception. And increasingly there are papers suggesting that there is no real reason to stop that. It's much better to use emergency contraception as your first line measure than to go and get a backstreet abortion. So this is what is happening. And then the last thing, and this I think is a very important issue, is to move away from one-off training. In many countries, 80% of the budgets are spent on one-off training. So you have one-off training for health workers, and many studies show that the benefits of one-off training over time are very limited. So what we really need to do is put in place a package of actions to improve health worker performance. Clear job descriptions, good quality training, desk reference tools, supportive supervision, collaborative learning. So we've talked about laws and policies, we've talked about improving the quality, friendliness of service provision, but we need to move beyond that to link good quality contraceptive provision to complementary interventions to address social determinants of use. It's a very well-written, interesting review by the International Center for Research on Women, which talks about provision, but talks very much about what are the interventions we can use to desire to avoid, delay, space, or limit childbearing, desire to use family planning, and agency to use family planning. So without that, as this wonderful review points out, McQuiston published in 2012 is, if early childbearing within marriage is socially acceptable, or early childbearing outside marriage is socially acceptable, simply increasing contraceptive availability and information on its own is not going to have any effect. We really have to address adolescents' lives in the context of the social drivers of early pregnancy, of coerced sex, and things like that. Let me move to the fourth part of my presentation. So what we said is a never before opportunity. What we said then was there are barriers. barriers to obtaining contraceptives, barriers to using contraceptives, and barriers to using them correctly and consistently. Then we've said we have now 20 years since the ICPD, the International Conference on Population and Development, considerable knowledge about what to do. How do we translate this and take this into action? The first thing we need is we need enabling national laws and policies that require health workers to provide contraceptives to adolescents without restrictions, which are formulated and communicated widely. We did an analysis of South Africa's contraceptive policies using WHO's 25-item human rights analytic framework. And we found that it was not bad, but there were shortcomings. But we are now doing one for Paraguay and one for the Philippines, and they are in a completely different spectrum. So you have huge barriers, just like the DRC one. The second thing is we need sound strategies. Strategies that are evidence-based, context-specific, with budgets to deliver the package and indicators to track progress. Now, the Global Financing Facility is supporting the development of investment cases in a number of countries. We've looked at these investment cases with an adolescent lens. Many of them are completely adolescent blind and adolescent contraception blind. So what we've tried to do is, in Liberia, support the development of a strong adolescent contraception component within the context of the investment case. So what we've said is they're going to get money from the World Bank and other sources, $10 million to strengthen sexual and reproductive health, with a big focus on contraception. So given that, we said we don't need to take from the $1 million adolescent budget for refurbishing facilities, recruiting staff, stocking contraceptives. That's for everyone. Within that context, the adolescent specific actions are here. Providing sexuality education in school and out of school. Building individual and social assets like the ICRW review. Improving access to contraceptive information and services to a range of delivery points within health facilities, outside health facilities, and of course improving access to HIV testing and care. And what we have done is we have built in indicators. Not just the MDG indicator of, pregnancy in adolescents, but actually input, process, and output indicators which can be tracked and which can inform and reshape programs. The third thing is we need to implement with fidelity and careful monitoring. We published a paper last year on what doesn't work in adolescent sexual and reproductive health. And one of the things we said is, we know that sexuality education programs work when they're implemented well, but they're implemented sloppily in many places. The same thing with adolescent-friendly health services. So we need to implement proven interventions well, and for that you need systems and structures in place. For instance, in Mozambique, they wanted to put in place a multi-component intervention. So what they did was they brought together Ministry of Health, Ministry of Education, Ministry of Youth, at the national, provincial, and local levels, with young people involved, NGOs involved, and so it was a multi-sectoral approach, but the systems were in place for making that happen. It doesn't happen otherwise. And we need program reviews periodically. The fourth thing is we need program reviews. A recent program review in Bangladesh pointed to the fact that many unmarried adolescents are not able to obtain services. So what you then have is, if you don't have program reviews, and this program reviews after 15 years of programming, this kind of program reviews, as we have learned from child health, from HIV, needs to be done every year, every 2 years, so that there's collective learning and we can move as we go. And the last, this is just to make the point that sexuality education is effective, but the problem is, in many places it's implemented poorly. And for that, this wonderful paper by a group of Dutch people whose surnames I can never pronounce, but a wonderful paper which talks about sexuality education. If you want to improve its performance, you have to work at the student level. Is the student interested? Is the teacher able to deliver? Is the school supporting the teacher to deliver? Are the family, the communities, and families supporting the school to function. So what they're doing is a whole school approach to sexuality education, which is, so it says we know how to do this in boutique projects and in research studies, but if we want to do it at scale, we need implementation research to demonstrate how it's happening. Just to conclude, there are positive deviant countries which are already made progress, which can both do two things. One is they can tell us that it's doable, it's possible to do, and second is we can learn from these countries. And these countries are not all in the north. 3 examples. Estonia, small, relatively wealthy country. At the end of the Soviet Union, they put adolescent health as a priority. They put in place sexuality education and services at the same time, and over time they produced enormous results both in reductions of abortion rates, birth rates, STIs. Of course, small country, you can say, European country, next to Sweden, you know, don't give us this example, let's go to the real world. And the real world is Ethiopia. Ethiopia is a country where, if you close your eyes, the images of Ethiopia are war, a small child malnourished, flies eating the secretions on their face. In 10 years, they've transformed through very good health investment and good leadership. Ethiopia is a largely rural population. They put in place a major community health worker program led by the government, financed by the government and by others, and look at the increase in contraceptive use. They've increased contraceptive use in married adolescents in the rural areas from 5 to 40% over 10 years. So Ethiopia has lots of problems. They have a problem going on in Oromia. But what they've done is they've invested, shown leadership and shown results. Bangladesh is another country. Look at the result, the decrease in child marriage, decrease in fertility. And lastly, Bangladesh. I gave you the example of Bangladesh's ASRH programs. Some of them are good, some of them are using evidence-based approaches, many others are not. But what they've done, Bangladesh, is they've really moved ahead with child survival, maternal health. Look at fertility rates, look at contraceptive use rates, and with investment, look at child marriage rates, and with investments in primary school education, which is hugely and steadily increased, what you have is the gender parity index at the tertiary level, and more women in formal sector wage employment. We've all heard about garment factory workers, but even in other areas of work. So that brings me to the end of my presentation. I'd like to close with 5 points. One is a never before opportunity to strengthen adolescent sexual and reproductive health, including adolescent contraception. There are huge barriers that we all know. Barriers to provision, barriers to use, barriers to consistent use, barriers to correct use. We know much more today than we did 20 years ago. And there's a lot of evidence available of how to do good quality contraceptive information and service programming. We need to take this knowledge and apply this in countries. And this never before opportunity with money there provides us with very good results. But I lived in Zambia for 10 years, and one of the expressions they used in Zambia is you need the right person with the right equipment at the mine head, in the mine shaft, but at the mine head. If you want to hit the cobalt and the copper, you need the right person at the right place with the right equipment, and that's what we need for these investment cases. If you don't, you get the same peer education programs, youth centers, poorly designed, poorly implemented, not monitored programming, waste of everyone's money. And lastly, we have experiences from countries that we can draw from. So I look forward very much to engaging in this discussion with you and to talking to you about what we can all do to contribute and use this opportunity for adolescents. Thank you very much.